Hello everyone, my name is Nada Sharif and in this video I'll be presenting my case study for Practicum 2. So I'll be introducing you to my case, my patient, why my patient was hospitalized, diagnosis, past medical history, medical management, discussion about medical management, and finally my references. So my case is from Hamad Medical ICU. And my patient was diagnosed with hemophagocytic lymphohistiocytosis, or HLH for short. This is an autoimmune disorder. So we'll see how it progressed to ARDS and how it was managed. So this is an interesting case because the patient required extensive RT intervention in its management. So to introduce you to my patient is a high schooler. She's a 15-year-old Egyptian female who is around 170 centimeters tall, which would make her ideal body weight around 64 kilograms. She has a history of bronchial asthma, for which she is taking bronchodilators PRN. Other than that, she had IDA or iron deficient anemia and tension headache. So what happened to her was on the 6th of February, she presented to ED, Aisha Latia Hospital, because of fever, cough, fatigue, basically persistent flu-like symptoms. So she was admitted to the wards as a case of lower respiratory tract infection. And 4 days in the wards, she developed hypotension, desaturation, tachycardia. And RRT was activated. They gave her fluids. They put her on 6 liters per minute on simple face mask. And then she was shifted to MICU in the same hospital because she was requiring higher and higher oxygen support. 2 days after that, because of persistent hypotension and higher FiO2 needs, she was transferred to Hamad MICU. So in MICU, they had done a complete blood workup, and the most significant finding was that she had bicytopenia. So she had low white blood cell count around 2.3 and low platelet count around 85. So these are the normal values. She also had elevated liver enzymes, so they did a CT, which showed that she had hepatomegaly. So all these are key findings. All these findings, along with her symptoms of prolonged fever, fatigue, cough, they're all consistent with HLH, and it's also part of the scoring system for HLH. So this patient had a high HLH score, and they did a bone marrow biopsy to confirm this diagnosis. So quick overview about HLH. It is a rare cancer-like autoimmune disorder where lymphocytes, histiocytes attack your tissues and organs, and these cells can build up on your spleen and liver and cause them to enlarge. So that's what we saw in the CT with this patient. She had hepatomegaly. And like most autoimmune disease, it could be either familial or it could be secondary to infection, like what we're suspecting with this patient. So how does it affect your lungs? So since this is a hyperinflammatory syndrome, it can trigger cytokine release, increasing capillary permeability, which means fluid can build up. And what does that mean? Pulmonary edema, pleural effusion, etc. Now that could explain why our patient was requiring higher respiratory support and higher FiO2. That could explain why when we received her, she was already on NIV, on pressure support of 10, PEEP of 6, FiO2 around 60%. And the FiO2 requirements were going up. She was tachypnic and she was self-proning. The chest X-ray on the left is the one taken from ED, and the one on the right was taken from MICU around 7 days after that. So you can see there's blunting of costophrenic angles. The patient had developed pleural effusion, and also if you look closely, you can see infiltrates are beginning to form bilaterally. So because of the poor chest X-ray and because the patient was restless, tachypnic, requiring high FiO2, it was decided to intubate her. And on the 13th, she was intubated with size 7.5 tube, secure 22 centimeters at the lips. She was connected to volume controlled CMV mode, volume set at 380 mils, PEEP of 10, rate of 24, FI to 100%. Now, if you look at the PEEP and the FiO2, it gives you the picture that the patient has refractory hypoxemia. So they did a lung recruitment maneuver. NMD percent showed 50, which is more than 41%. So what does that mean? The patient's lungs are recruitable. So we can go ahead with the high PEEP, low FiO2 strategy of ARDS management. and optimal PEEP was found to be 18. But when they set when they set the PEEP to 18, the patient could not tolerate high pressures. She became hypotensive, so because of which we had to come down on the PEEP to 14. So immediately after that, she was started on lung protective ventilation as the patient was meeting the ARDS or Berlin criteria. So her symptoms had begun within 1 week. Bilateral opacities were forming on the chest X-ray. PF ratio was 80. And she also did not have any cardiac issues. So the volumes are dropped down to 340, which is in the 4 to 6 mils per kg range. Rate went up to 26. PEEP was set at 14. FI was set at 80%. So this was the ABG after intubation. So what's significant here is the PO2 is 80 and PF ratio is 80. So that means her FiO2 should be set at 100%. So she had severe ARDS because the PF ratio is less than 100. And literature supports severe ARDS patients to be prone early on. So that's why she was prone at 11 o'clock, and when she was prone, they were able to come down on the FiO2 at 55%. So when she was still prone, the PF ratio improved significantly to 180. After 18 hours, she was deproned, but while they were deproning, she had a desaturation episode, so they had to come up on the FiO2. They went all the way to 70%, and this was the PF ratio after deproning. So the PF ratio dropped to 116, so they went up on the PEEP to 18, and this time they had a close eye on the blood pressure because they didn't want what happened last time to happen again. They didn't want the patient to become hypotensive. But after the PEEP was increased to 18, the patient improved. Her PF ratio picked up to 178. Other than that, the blood gas was normal. After this, they addressed the pleural effusion. So a chest strain was inserted on the left side. And after that, over the next few days, the patient was stable. All they did was titrate ventilator settings, especially the FiO2 and the PEEP. And on the 20th, we were able to come down on the PEEP and the FiO2 all the way to 5 and 25%. So we started the first PSV trial on pressure support of 10, PEEP of 5, FiO2 25%. But she failed the trial because of tachypnea. So the plan for this patient was daily SVT and sedation vacation. So moving on to discussion, I think this case was very well managed. From the diagnosis to how they treated ARDS, they went step by step. Initially, though, I thought they could have done the chest drain right after the X-ray, but the patient was very restless, hypoxemic, hypotensive, so they had to intubate. And even after intubation, the focus was on managing ARDS because pleural effusion by itself was not going to cause severe respiratory failure. At least in this case, we had to manage the oxygenation and ventilation of the patient first to prevent further hypoxic insults because of ARDS. And also ARDS patients, they don't really tolerate large fluid shifts well because of which we had to be extra careful with the chest drain insertion. But that's not my focus. What I want to focus on is proning. Specifically, I want to talk about the infamous PRO-SEVA trial or proning severe ARDS patients trial. So this is a 2013 RCT, and the findings were very impactful in global ARDS management because this study is why we prone patients for 16 hours or more, because it demonstrated that early and prolonged proning significantly reduced mortality rates in severe ARDS patients. So our patient had severe ARDS and she was prone for how long? 18 hours. So if you want to learn more about proning, I highly recommend looking this up. I'll link this study in the description. So that's it. That was the case. So what began as an ordinary cold in an otherwise mostly healthy high schooler spiraled into ARDS, something far more serious and life-threatening. And this is one of those cases that required RTs at every step of the way. So we started the patient with NIV, which escalated to intubation and lung protective ventilation, recruiting patient's lungs, working with the patient's physician, all to ensure the best outcomes through evidence-based practice. So with that being said, thank you for your time. Thank you for listening. These are my references. Thank you.